My hello to all of you. I am Dr. Sachin, psychiatry faculty, consultant practicing psychiatrist in Dwarka, New Delhi. I am here to discuss today a important topic, a violent patient in emergency. This is what we call as code red in psychiatry. Please don't be confused. Code red also mean a fire emergency in a medical hospital or a college or anywhere else. But in psychiatry, what code red means? Code red is not fire in psychiatry. So today, in the next 20 minutes, I am going to talk what code red means in psychiatry, what is the protocol to be followed in emergency, and what are the different causes and its management. This is a part of the CME that I have taken in a national psychiatry national conference multidisciplinary HopeCon. So since I shared this on my social media, so many of the people who did not attend the conference, they were willing to listen to this. So I am recording it separately for all those who are interested. Code red means any psychiatric emergency that requires that has imminent risk of violence, suicide, or serious self-injury. Violence, suicide, or serious self-injury requiring immediate clinical and security intervention. Requiring immediate clinical and security intervention. This is code red. So violence, suicide, or serious self-injury requiring immediate clinical and security intervention. So as we said, code red protocols ensure safety first, not only of the patient but also of the team. It is your responsibility as an emergency physician to ensure safety of the patient, the nearby people, yourself, and your team who is treating. Whenever there's a code red indicated in a hospital, remove the non-essential persons from the immediate area. So there should not be anyone who's not supposed to be there in the reach of that violent patient. Ensure no dangerous objects are within the patient's reach. So please, this is the first three code red protocols. Okay, and secure other patients safely. Then, what is the most important? Rat. What is the most important? This is made by me. In emergency code red, you have to be rapid. You can't take too much of time in taking decision. You have to be bloody accurate, 100% accurate, and you have to know triage. Please mark my word. All violent patient does not mean psychiatry. All violent patient does not mean psychiatry. So today's CME is not only for psychiatry people, it is also for other disciplines doctors, because any one of you might have come across a violent patient in emergency, anybody who deals with emergency. So just like we have ABC in a medical emergency, airway, breathing, circulation, this is my ABC of a psychiatric emergency. Number one, agitation or alertness. Agitation should be addressed first before starting detailed evaluation. Many a time detailed evaluation may not be possible in case of an emergency. Many a time detailed evaluation may not be possible in case of an emergency. So you have to first ABC, agitation, alertness. Then beware of masquerading medical condition. I just mentioned all violent patient does not mean psychiatry. There are so many behavioral patients, so many medical patients that present with behavioral manifestation or emotional disturbances. Please make sure to check vitals, the lab data, poisoning, seizure, drug toxicity. I'm not going into the too much of details, but you should be aware that there can be a medical condition. And see, consider a wide variety differential of psychiatric diagnosis. Please understand, in emergency it is not important to have an exact diagnosis, rather it is important to have a working diagnosis, because your treatment would be started at an empirical level of diagnosis. So treatment would be interwoven with evaluation. Treatment would be interwoven with evaluation. It has to go side by side. Epidemiologically speaking, 5% of all emergencies are psychiatry related. 5% of all emergencies are psychiatry related. Of all the psychiatric emergency, 20% are suicidal, 10% are violent, and 40% require hospitalization. 20% are suicidal, 10% are violent, and 40% require hospitalization. What is the question that bothers? I am not a psychiatry doctor. I'm an MBBS doctor, I'm an MD medicine, I'm an MS ortho, I run my hospital, I run my nursing home. Am I allowed to treat psychiatric violent patient? Am I allowed to deal? Does the law or the guidelines allow emergency treatment to be given in a non-psychiatric setup also? If anybody is attending this on YouTube, can you comment on this? Does the guideline allow a non-psychiatric doctor to treat a psychiatric patient in case of emergency? Yes. Answer is yes. As per Mental Health Care Act 2017 guideline, any medical treatment, including treatment of mental illnesses, may be provided by the registered medical practitioner to a person with mental illness, either at health establishment or in the community, where it is immediately necessary to prevent: number one, death or irreversible harm to the health of the person. If the person is at risk to cause a harm to himself, death or irreversible harm. Number two, the person inflicting serious harm to himself or to others, harm to himself, harm to others, or harm to property, the person causing serious damage to property. So in these cases, emergency treatment can be given in a non-psychiatric setup for a maximum period of 72 hours. For a maximum period of 72 hours, beyond that you have to shift into the psychiatric hospital. For the first 72 hours, you can give the treatment in a general hospital, provided these three are the indications. So acute intervention is required, that is behavioral emergencies, when the patient is at risk to himself and then the patient is at risk to others. Risk to himself means self-injury, suicide. Risk to other means violence. Today I am telling that all medical professionals, whether you are psychiatry or non-psychiatry, should know how to deal with a suicidal attempt or self-harm, should know how to deal with a violent aggressive patient known as acute excitement. Please understand this: acute excitement is not the only domain that belongs to psychiatry, it belongs to anyone. What are the different causes of violence behavior? Acute psychosis, that is exacerbation of schizophrenia; acute mania, substance related psychiatric disturbances; personality disorder. But we are not here to elaborate on the causes. We are here to deal with how to deal. Today's topic, I have omitted the suicide or self harm part, that I'll take in a separate CME some other day. How to deal with a suicidal patient, how to talk to a person who has attempted suicide, self harm, how to prevent further suicide, that is the gatekeeper training, whatever, we'll talk about it separately. What are the warning signs of impending violence in a psychiatric patient? Yes, this image is created by ChatGPT, but these signs are important. Verbal threats: a person who is giving you verbal threats is likely to attack. Agitation, pacing movements, clenching of fist and jaw. So doctor has to be careful that the patient is doing clenching of fist and jaw. Then signs of increased activity include pacing up and down, pacing up and down. A recent violence: a person who has attacked family members at home and brought to your emergency can attack you, can attack family members again. So the recent violence. Then loud voice, always before hitting a person, it is very common emotional tendency that first you will raise your voice, then you will become verbally abusive, bad words, filthy language, and then you will attack. Startle behavior: a patient is looking at you, startle, a verbally abusive patient. You have to know these are the signs of impending violence. If this is happening, you have to be more careful, be more cautious. Do not carry any object that can be used as a weapon. You might have seen many of the psychiatrists not carrying stethoscopes. You might have seen that we avoid the objects that can be used to give a harm. On approaching the patient, stand in a non-threatening posture. You cannot approach a violent patient like this. Hey, what? What? So you cannot be threatening. Don't think that if he's getting violent and you scare him out and he will not attack. A scared person attacks. So don't be threatening towards. At least remain at an arm distance from the patient and ready to uh, protect. Okay, then avoid direct eye contact for a long duration. It is in contrast in psychiatry routine setting where you do direct eye contact, but prolonged excessive direct eye contact, especially for people who are paranoid, who are suspicious, might trigger. Then Do not turn your back until you are at safer distance. Suppose patient is here and I'm talking, and then I turn back immediately, the chances of attack are more. If I turn back, the chances, so I turn back when you are at a safer distance. Walk like this and then turn back. Though all these things are important if you are a psychiatry resident. Stand together with the staff and closer to the exit. Then if the patient has a weapon, once I also got an emergency psychiatry call that patient is violent but he is carrying a pistol, so one should refuse to perform the examination unless it is surrendered. And please don't try to take weapon away yourself. Please don't try. Okay, if it is suspected that the patient might have a weapon, call security or police. A doctor is not supposed to take weapon in from the hands of the patient. So what are the interventions for an aggressive patient? Three level of intervention. Verbal de-escalation, which we the psychiatrists are very pro about, how to handle a patient verbally. Then chemical restraint. Today I want to tell all of you how to restrain a patient, how to sedate a patient chemically. And last but not the least, physical restraint. Please remember, physical restraint is the last resort. Physical restraint is the last resort, not the first. So there's a 10-step verbal de-escalation. Remain calm, listen properly, respect the personal space of the patient. Don't go too near, don't talk very far from. Then do not be provocative, do not provoke the patient. Okay, be very careful. Establish a verbal contact. Okay, establish a verbal. Don't directly go and touch the patient. Establish a verbal contact first. Talk to the patient. I am here to help you out. Let's talk for a few minutes. Okay, be concise, don't be very elaborative in the conversation. Many a time psychiatrists have become elaborative, that you are talking more and the patient is talking less. Be more concise while talking. Okay, specify, identify wants and feeling. What does he want? Why he's getting violent? Identify wants, identify his feelings, and show some empathy. Speak very clearly. Listen actively as if you are interested in what he is speaking. Don't be distracted while you are listening to him. Agree or agree to disagree. It is one of the most important skill. I agree that you are getting angry. I understand that you are feeling like hitting. I understand that you are feeling like breaking things off. But I completely disagree that this is right. You can tell the patient it's okay to feel angry, but it is not right to hit somebody. It is not right to break things. Okay, anger does not justify. Set clear limits. Set clear limits. If the patient is verbally abusing you and you are talking to the patient, tell him that these are the words you are not supposed to use in front of me. Set clear limits. Offer choices and optimism. Tell him there is a way out of the crisis situation. Be a little more optimistic. Okay, then debrief and reinforce cooperation. These are 10-step verbal de-escalation that can be remembered by the mnemonic. Diffuse. Decide. Not all patients are candidate of verbal de-escalation. That is very important for you people to understand which patient should be given verbal de-escalation trial or not. Ensure safety while doing verbal de-escalation. Form relationship. Introduce yourself. Tell that you are not from their family member side, because many a time paranoid people who are paranoid from their family member also become paranoid from the doctors. So tell her, make a neutral relationship with the patient and then talk. Utilize interest. What do you mean by utilizing interest? Talk about any topic which is common to both of you. For example, by profession he's a doctor, by profession he's a artist, by profession he's a singer. Talk about something related to his profession that you know. Talk about some neutral topic, not the area of conflict. Set limits and reevaluate whether he needs de-escalation or not. What is chemical restraint? This is important for all the doctors to know. Sedating a patient, there are two types of tranquilizer: benzodiazepine being a minor tranquilizer and haloperidol or neuroleptic being a major tranquilizer. Many a time psychotic individual don't get settled with benzodiazepine alone, because psychosis means dopamine, benzodiazepine means GABA. So please don't think that all of your patients will get sedated on midazolam, lorazepam. Some of them may require haloperidol. So what are the different options? Either you give oral or a parenteral drug. Oral drugs, many a time patient is not cooperating, so we have to give parenteral, IM or IV. Then mouth dissolving preparations we have nowadays: lorazepam, lorazepam, metazolam. We have this liquid formulations available. Even Valproate has now risperidone liquid. We have haloperidol liquid. We have now what is to be given? The major tranquilizer haloperidol doses 5 mg to 10 mg, 1 to 2 ampules plus promethazine 1 ampule, 25 mg to 50 mg IM. I prefer giving haloperidol plus promethazine, the famous brand name Serenase Finargan intramuscular rather than intravenous, because there have been reports of cardiac arrhythmias after haloperidol intravenous. Lorazepam, Lopez, Loranza, so many injections are available. 4 mg to 8 mg, 1 to 2 ampule. This you can give IM or IV both, but directly preferred rather than giving in a drip. I am IV diazepam 5 mg to 10 mg. So this is my sequence. This I prefer for psychotic individuals. This is less, and this is even less. Now, what are the guidelines for restraint? MHCA says, Mental Health Care Act says that a person with physical restraint should all patient with mental illness should only be physically restrained when this is the only means available to prevent the harm, and it is authorized by the psychiatrist in charge of the patient inside the hospital where the mental health establishment is there, and it should not be period used. Restraint should not be used for a period for more than what it is required. So restraint should be used for a limited period, not for a longer period than what it is required for. Okay, there are 4-point restraint. So explain to the patients and the family why restraint is required. One team member to be assigned to each limb. 4-point restraint means like this: one arm here, one arm here, one abducted, one adducted. One upper limb should be tied in abducted position, and one over the head and another in adducted position. One is abducted, another is adducted. Okay, so there should be short ties. Canvas should be tied so that two fingers can be easily inserted between the skin and the canvas. So this is restraint. Summarizing, the takeaway point is you have to understand the early signs of crisis. You have to understand the early sign of crisis. You have to prioritize safety and structured assessment. Prioritize safety and gradually structured assessment. Know your emergency medicines. All of you should know haloperidol, lorazepam, diazepam, haloperidol, lorazepam, diazepam, haloperidol, serenase, haloperidol mixed with promethazine, finargan, lorazepam independent, diazepam independent. You should know the dosage. You should know mouth dissolving formulation. You should know liquid formulation. Work as a team under pressure. So this was my short and sweet presentation on handling a violent patient. I would wait for your comment, suggestion and feedback. I finished in time, and thank you so much for listening out to me. This is where you can reach out to me: Instagram, Telegram, my YouTube channel, and this is my contact details. That is all from my side for the day. Thank you so much.